Jim Meadows again with the solution and explanation of the second case. This is a lumbar disc herniation, and as with the first case, and possibly even more importantly now, we must define terms. There are multiple factors that confuse a clinical diagnosis of disc herniation. It is not that the diagnosis is difficult when it is present, it is that many other conditions are often misdiagnosed as such by physiotherapists. This confusion comes from two main sources: Robin McKenzie and the internet. Mackenzie's model of disc herniation in context. In the 50s and 60s, both Cyriax and Mackenzie had similar views of this diagnosis, and they were based on a speculative model that had the advantage of pretty much not being disprovable, and which worked for them, even though it was unlikely to be true. At that time, the only imaging possible for low back pain was X-ray, and this was of no real use in making the diagnosis, especially as the state-of-the-art X-ray then was poor by today's standards. The diagnosis disc herniation contained a hodgepodge of dysfunctions, some of which we would recognize today as segmental dysfunction, disc protrusion, and Cyriax actually used protrusion and herniation interchangeably at times, and central and lateral stenosis. If today's neurosurgeons were presented with many of Mackenzie's disc herniation diagnoses, they would not recognize it as such. And I've said many times that if you want a definitive statement on how to recognize a medical condition, go to a medical textbook and not a physical therapy test, unless it is in agreement with the medical book. This is doubly so for surgical conditions. The second source of confusion is the internet. And the problem here is that there is so much information available that it is sometimes difficult to know what is quackery, what is just wrong, what is relevant to you, and what is right. The current trend is that everybody's opinion seems to be equally valid, and this can only be incorrect and lead to confusion. Even from the credible authorities, the question of relevancy arises, and this is true of them with distance. Almost all of the articles found on the internet now are from a radiologist's perspective and relate to how the image of the disc lesion appears rather than the actual pathological consequences and clinical appearance of the herniation. This is of very little use to us. Impact still finds that the older method of categorizing disc lesions is the most useful clinically, with the understanding that herniation means the abnormal migration of one tissue through another. This categorization is as follows. Disc protrusion, a bulge without nuclear migration and therefore not a herniation. Essentially, it is a weakness that allows the annulus to collapse, usually in one direction, but sometimes circumferentially. The significant direction of collapse to us is towards the posterolateral corner of the spinal canal, where the sensitive structures live. If the protrusion is large enough, then it is reasonable to postulate some compression of the dura and a moderately limited straight leg raise. Otherwise, it is likely to be mistaken for a segmental dysfunction if smaller. Disc prolapse. There is directional migration of the nuclear material, but it remains confined to the annulus. But the hernia causes considerable compression of the neuromeninges and lead not only to a limited straight leg raise, but also in a radiculopathy if the collapse is large enough. Disc extrusion. The nuclear material bursts through the annulus and becomes external to the disc. If this is towards the posterolateral corner, then significant compromise can result and a radiculopathy is very likely, especially as the nucleus is neurotoxic and simple contact with the nerve can in itself do damage. Disc sequestration. The extruded material ruptures and the fragments, and the consequences depend entirely on where these fragments end up. Another form of disc herniation is termed a contained herniation or an internal derangement of the disc. Here the nucleus does migrate, but it spreads around the disc without actually bulging it. Initially, this spread is through the circumferential clefts, but later it can destroy the annulus itself and spread that way. The pain now is not caused by compression of sensitive structures, but comes directly from the outer part of the annulus, which is chemically irritated. The operational definition or essential illness script for the average disc herniation is as follows. 1. Severe back and leg pain. 2. Obvious rhodoscoliosis. An inability to move in any direction. An inability to walk without a severe antalgic gait. 5. A very positive straight leg raise, 30 degrees or less often, and possibly a cross straight leg raise. All range of motions are very restricted and painful. If a radiculopathy is present, you can expect to see one or usually more and sometimes all of the following associated with the above. Neuropathic pain. This indicates that there is damage to the nerve and not just simple compression. Weakness of the muscles most heavily innervated by the affected segment. That is the myotome. Sensory loss in the segment, particularly in the autogenous area of the dermatome. Hyporeflexia in the segment. True denervation paresthesia as opposed to dysesthesia when there is hypoesthesia underlying it. As you can see, this is not the lesion that will improve with shift correction or half push-ups. In fact, in both instances, you are likely to severely increase the patient's symptoms if you try them. I think you can say with confidence that if either of these two techniques work, then you do not have a disc herniation. Differential diagnosis. There isn't much that can look like a disc herniation when it causes a radiculopathy, but here are some ideas. Tumor on the spinal nerve, either actually in the spinal nerve as a neuroma or on the adjacent bones compressing it. These will give the signs and symptoms of a radiculopathy, but will not give the non-neurological signs. In fact, the range of motion will be relatively minor in its loss. Fracture. A compression fracture will cause the same severe low back pain, but the onset will require x-rays to eliminate a fracture, and this should not reach the therapist. Lateral stenosis. If severe, it can cause a radiculopathy or at least a severely limited straight leg raise, but the physical signs will be extension biased. An adherent spinal nerve root. Following a disc herniation, and with time, if the nerve is damaged, it can become adherent. In these cases, forward flexion and the straight leg raise will be limited and very painful, but the remaining range of motion, as opposed to the neurological signs, will be minor or absent. A lateral disc herniation. This is not so much a differential diagnosis as it is a different type of herniation. Sometimes the disc can be directed laterally rather than posterolaterally, and it misses the dural sleeve and causes neuromeningeal pain and signs. They are not common and tend to affect the upper levels more than the lower, but they are so atypical they can be misdiagnosed. But when they are, the misdiagnosis is always for something worse, such as a disease process, so little harm is done. Contained herniation. As described above, it is almost entirely discogenic. These tend to occur in the late 20s to early 30s, and the pain is progressive and pretty much unrelenting. Standing, sitting, walking all bother the patient, and range of motion testing demonstrates varying limitations depending on how severe the problem is at this point. But all movements are affected to some extent, and particularly so flexion. The straight leg raise, though, is either negative or minimally positive, and there is no radiculopathy. In short, then, a lumbar disc herniation is a catastrophe for the patient and not an inconvenience. Thank you.